Thanks, Ankita, and thanks for the opportunity for Dr. Bhavin sir as well as Dr. Ankita. So, without wasting time, let us start. What I'll do is we'll call the names who have volunteer one by one. We'll take it. So, let us go now. So, first thing, so Dr. Deepak, you can unmute it and take a few seconds. There are two X-rays. What you feel? Both pathologies are same. Both pathologies are different. And what is the pathology? We running off little short of time, so we'll try to take it at 4 minutes each case.
Yes. Uh, Sir, on the right side, pneumothorax is there, sir.
Okay.
Uh,
So basically there are two images.
and
This one is
fracture.
as per yeah.
Yes, sir. And
Okay.
fracture, rib fracture is there, sir. Posterior aspect.
Okay. Of the
Uh, Posterior aspect of right uh, fourth and fifth ribs are there, sir. Fracture
okay. Anything else?
with associated pneumothorax.
Very good. Okay.
Mhm.
And on the left side, what did that X-ray showing?
Uh, Sir, there also hyperlucency I'm able to see in right lung
Very
field.
good. Very
Looks like pneumothorax only, sir, for me.
okay. Very good. My question is, what is the difference between these two areas of pneumo? So basically, for both of you are telling this
Right.
is a pleural line, correct? Which has
Yes, sir.
highlighted due to this. So does what pneumothorax will be limited to the pleura, or it will extend beyond the chest wall?
Will be limited to the pleura, sir.
Very good. So are you seeing this part? I think the line is ending here. Here the line is, I can see it is going through and all to this. Do you think that pleural line will be so thick, big? Pleural line will be so thick, big if it is was pneumothorax. And what is the most important feature of pneumothorax? What we see after the pleural line, this if we think these are the pleural lines, correct? So as
Yes,
per
sir.
you, this is the plural line. Sorry, the pointer options. Okay, as per you, this is the plural line. So this is the plural line, correct?
Yes, sir.
So what is the most important thing we see that?
Sir, we have to look for absent broncho pulmonary
Absent
vascular
broncho.
markings.
Very good. Excellent, Dr. Deepak. So you are seeing there is absent bronchovascular markings here. What about this?
Uh, Sir, there is blending of right CP angle with homogeneous opacity in right lower zone.
Correct. Fine.
With
What I mean to say is about this line, are you able to see bronchovascular markings
uh,
in this
sir,
region,
yes,
especially this?
yes, sir. I'm able to see.
So yeah, so presence of the bronchovascular markings beyond what you are feeling as a pleural line will rule out the pneumothorax.
Okay, sir.
So the most specific signs of pneumothorax on a chest X-ray is the absence of bronchovascular markings. This is not a pneumothorax. This is a skin fold, which is
Okay.
mimicking like a pneumothorax. This is your day-to-day X-ray. This is ICU X-ray, which is presented with a breathlessness. Okay, so you have to be careful while calling it as a pneumothorax. Pneumothorax
Yes.
margins will be on the medial side as well as lateral side. If you see, are excellently very much well defined. There is absence of bronchovascular markings in this region, whereas the skin fold will be seen beyond the confines of the chest wall. Can you say this is going beyond the confines of chest wall? See here.
Yes.
So if you consider pneumothorax, it's a pathology of pleura. Pleura won't extend beyond the chest wall. So that is the first important point. Look at the thickness. It's almost like a 6 to 7 mm. Look at the thickness of pleural line. The pneumothorax pleural line is never more than a 3 to 4 mm in thickness. Look at the thickness. It's almost like a 7 8. And most important specific features has to be the presence of the bronchovascular markings. I'm seeing the bronchovascular markings present. So day-to-day life, X-rays, very important. Always remember, what is the one finding you think missed on this X-ray? See here, there is a step at the junction of medial two-third and lateral one-third of clavicle. This is a fracture here. See this.
Yes.
Yeah, so this is a clavicle fracture,
Skull
ribs
fracture.
fracture, which are certainly pneumothorax. Here, the skin folding is trying to mimic a pneumothorax, which should be treated cautiously. If necessary, you should repeat the X-rays in the lateral as well as the again PA view another in a 6 hours time. Okay.
Okay, sir.
Thank you, Deepak. Hope you got the concept of it.
Yes, sir. Thank you, sir.
Okay. So next case we'll move on. This is just a illustration. I like to ask Dr. Purnima, take your time, unmute yourself and see it. Others, you can answer in the chat box. I'm seeing the chat box for the answers. Dr. Purnima, go ahead.
There is a area of diffusion restriction in the high frontal regions, right high frontal region,
Okay.
T2 hyperintense lesion
Yeah, correct. So this
with
is a T2 hyperintensity.
surrounding vasogenic edema is there.
Okay.
It's showing blooming on SWI sequences.
Very good.
Oh,
Excellent.
likely, like either can be hemorrhagic mets or
Okay.
hemorrhagic infarct kind of.
Very good. So you have a T2 images which is showing little heterogeneous hyperintense, little restricted diffusion. This is T1 which is showing this. And this is a GRA,
Hyperintense.
and this is what are the T2 wetted images. What is
Yes.
there in the scan which are able to see other than this what you are describing? Where is the location as per you? Where is the location of the lesion?
I feel it's high high frontoparietal convexity.
Frontoparietal convexity. How we divide it? By knowing the
Central
level of the central sulcus, which is in
sulcus
its depth of gyrus. So because of the lesion, it has distorted. So this is which is going in the depth of gyrus, looking like a central sulcus. So it is in the post-central sulcus region.
postcentral parietal.
So, so what are in your mind's thoughts now? So lesion is T2 bright, some amount of heterogeneity on this. It is showing restricted diffusion. Major portion of the lesion is showing
Bloom,
blooming and
blooming.
some amount of T1 hyperintensity, which
Hyperintensity. Because it is hyperintense on T1 hemorrhagic component, I'm feeling so.
very good. So this is something hemorrhagic lesion. So what you think of the hemorrhagic lesions? What are your minds? Hemorrhagic lesions, brain hemorrhagic lesions. Kindly tell me.
Hemorrhagic metastasis.
Very good.
Um, less likely of infarct type feels like
Why you are feeling infarct? It could be infarct with hemorrhages, or it could be just a hemorrhages also. Can hemorrhage show the restricted diffusion?
more of blooming I feel, sir, rather than this
Okay.
much.
So okay, okay. As per the intensities, if it was a blood, which stage of blood it is?
Subacute
Very good. So it is a bright on heterogeneously
T1
hypo, but T1 it is heterogeneously hypo. So probably in a subacute state if it is a blood. So basically you have come to the conclusion that it is in the subacute stage of
subacute stage of blood.
blood.
Yes,
So
sir.
you have to find out what is the cause of it.
Of course.
Then how
Yes,
you are
sir.
going to find the cause of it. So what the things the scan is showing more to help you to point it out. Is it in the any arterial territory? Is it in the
Mm,
any venous territory?
venous venous
Does it is
infarcts.
in a does it in a any proper lesion type territory where it is a gray white matter junction for metastasis, or it is in a cortical lesion like a avium? So what do you think? Territory
Cortical lesion, I feel. Cortical
very good.
lesion.
It is a cortical, which is some amount of subcortical extension surrounding vasogenic edema is there.
Edema.
Does edema is showing restricted diffusion?
No, sir.
Very good. So edema is
Lesion
not
passive.
showing absolutely no restricted diffusion. So we have a T2 heterogeneous lesion, which having hyperintensity on T1. So
Hyperintensity T1
hemorrhagic lesion. So
temperature.
what is there in the scan? What we look for when we see the scan? Do we look for the phloids?
Sir, arteriovenous malformation like shows more of phloids.
Very good. I
Um,
mean to say, what phloids we look while seeing the scan on T2 weighted images? Do we look arterial and venous phloids? flow words. I mean to say, so this is
Peripheral flow is
so this is transverse sinus, correct? This is
sir.
blackish. This is right transverse sinus, blackish.
Sir.
What is happening to this sinus?
Superior sagittal sinus.
Very good. So
T1
you
hyperintensity is there, sir.
very
Likely
good.
thrombostomy.
Very good. Excellent, Dr. Purnima. So if you see, this is a T1 hyperintensity, which could represent a slow stasis or a thrombosis. But a
Thrombostomy.
Spinico T2 again shows there is a loss of flow wide.
Loss
Even
of
a
flow.
GR is showing the blooming images. It is in the venous territory of superior sagittal sinus. So when you see the image, always remember to see the flow voids. Very important. When you jump to the conclusion that it's being a mass or a kind, first of all, it is in the subacute of stage. T1 bright, T2 heterogeneously hypointense, restricted diffusion. So it is in the subacute stage of blood. Either has to be a vascular pathology, non-vascular, which could be a neoplastic or non-pleoplastic. Simplest explanation being the superior side. It is not in the arterial tree properly, and it is so much about rounded morphology, and we can see there is a loss of flow wide. So this is not what the CVT, the venous hemorrhagic infarct or venous hemorrhage. So always looks for the flow words when you see in the scan.
Sir. Okay, sir.
Oh, thank you. So we'll go for the next scan. Dr. Apeksha will take this next case now. So this we'll take it as a long case. This was just a start to start the session because those were the day-to-day practice, pneumothorax, skin fold, CVT, what you see. I want to see you describe this lesion as you are describing for a long case. Take your 1 minute time, describe it in a one shot, how you want to describe it. Sorry.
Good evening, sir.
Yeah, please continue with the description. Continue, sir.
Sir, I have been provided with a radiograph of PPH. Uh, there is a intertrochanteric fracture of the right side with
Okay.
superior displacement of the proximal femur, and
Okay.
there is a narrowing of right hip joint space.
Okay.
And there is osteopenia in the head and the neck region.
Okay, that is it possible that osteopenia will be limited to the one location and rest of the bones other than that, and pelvic bones will be normal? Is it possible that single area having osteopenia and other being completely normal? If yes, then what it implies?
So yes, in cases of avian.
Okay, very good. But does avian occurs in the intertrochanteric region?
No sir, matlab, head region. So.
Very good. It is a subchondral process. It should be is restricted to this area. Here, subchondral bone looks fine.
Yes, sir.
As you said, there is a fracture. What it implies? Is it a pathological fracture or a routine fracture where patient has undergone a fall?
So it might be a pathological fracture because there is lucency seen in the head and the neck region with
Very good.
adjacent
So you mean to say
sclerotic
this?
margins with
Very good. So
a
sclerotic
narrow zone of
margins.
transition, no soft tissue component.
Very good. So what is your diagnosis based on this? I would like to correct your first when you give an X-ray, first describe this at I have been provided with a pelvis and both hips of AP view of skeletally mature individual, which shows I am not actually, once you have said there is a fracture, you are correct, but I am not able to see a fracture line. What I would like to describe this, there appears to be a shortening of femoral neck with minimal superior migration of greater trochanter, which has resulted into pseudo reduction in the joint space along the lateral aspect of right hip joint. Subchondral region appears normal. There appears to be ill-defined lucency in the head neck region. This is what I feel is some lucency is there, which probably some amount of sclerosis, but rest of this is fine. I would describe it as a well-defined expansile, a lytic lesion without any obvious matrix, without any obvious areas of periosteal reaction, no definite cortical break I am able to see, no definite associated soft tissue I am able to see, narrow zone of transition is present, and associated shortening. The rest of the bones, I would like to keep it as a normal. So based on the description, what you think it is a pathological fracture, what your DDs and what you would like to do now?
So lytic lesion
Very good.
with sclerotic margin.
Very good. Sclerotic margins is pseudosclerotic margins because you cannot see the sclerotic margins across this area. So the sclerotic margins, what you are defining is limited to the anterior aspect, which is nothing but the actually compressed normal trabecula of the adjacent bone. Because if you say sclerotic margins, it has to be present along the all margins of the lesion.
Okay, sir. So in this
Okay.
mature skeleton, sir, I would like to give differential diagnosis of giant cell tumor.
Okay, very good. Next.
Mm, okay. Simple bone cyst.
Simple bone cyst is the diagnosis of immature skeleton, mature skeleton.
Immature skeleton, sir.
Very good. Next.
Uh, s- uh, so can be chondroblastoma. Metastatic lesion can also be present.
Okay, very good. Does meta that is also good. Really, what you want to do next now to characterize it or to see the extensions?
MRI, sir.
Okay, take this MRI then. We'll go for MRI. Okay, this is the MRI.
Okay, so I have been provided with the axial sections.
Okay, just describe it. Don't just directly describe what you're seeing.
So there is a T1 relatively hypointense lesion with T2 with multiple air fluid levels on T2
Okay.
and
Do you think this series is what T1 or T2 based?
so T2 based.
Very good. So
T2.
only
So
T2 based sequence. Okay.
yes.
So tell me, describe it first.
So on T2 sequences, the multiple fluid levels are seen within the said lesion.
Okay.
So which suggests secondary ABC changes.
Secondary ABC. Why can be primary ABC? What you have to describe the lesion? Lesion is only showing fluid levels or lesion is hypointense? You take another view
So,
again. One.
lesion is showing
So basically, when you are providing, what you are seeing is, if you see last image, is a blackish lesion, T2 hypointense, well-defined rounded lesion in the head neck subarticular region of the femoral neck head region. Okay. So if you see major lesion is blackish, can you see this? This is a blackish
yes,
part of the lesion. And multiple fluid levels, as you described, are present is there. And we
and
can easily say there is a presence of the fracture due to this. So basically, this is a pathological fracture. So are you seeing that the articular surface is preserved?
yes, sir.
So it is not going into the articular surface, not involving the joint, doesn't show some significant periosteal reaction, mild amount of soft tissue is there. Now, what your DD remains?
So, and the lesion is showing a hypointense rim around it,
Very good.
which can suggest the sclerotic rim, sir.
Okay. So what
And
your DDs are there?
so my differential diagnosis is, sir, GCT with secondary and ABC changes,
Okay.
or uh, uh, osteoblastoma with secondary ABC changes.
Osteoblastoma lesion, what is the most important feature of osteoblastoma lesion? Does it occur in immature skeleton? What is the age? What are the locations? Does it have a periosteal reaction?
No, sir.
Okay. Second DD. So tell me the causes of secondary ABC. You told that this is secondary ABC. Tell me the causes. List me 5 causes of secondary ABC, which can present as a blood fluid level. You are telling secondary ABC just because it's a skeletally mature individual which has a multiple fluid level. So primary ABC usually and exclusively occurs in immature skeleton. Correct? So this is
Yes,
the
sir.
secondary ABC. So give me the 5 causes of secondary ABC.
Sir, fibrous
One is
dysplasia.
already told.
Fibrous dysplasia,
Okay, very good.
GCT,
Okay.
osteoblastoma,
Okay. Osteoblastoma, does it cause it or osteosarcoma causes?
osteosarcoma, chondroblastoma, sir,
Okay.
and osteosarcoma also, sir.
Hmm. So basically, the most important when you get the case, you will be provided with the 5 definite questions. These are what are the secondary causes of second? What are the causes of secondary ABC? Most common being GCT, then a fibrous dysplasia, CMF. Then you can present chondromyxoid fibroma, then NOF, then chondroblastoma, and osteosarcoma. These are the causes of secondary ABC. So when you provide it, always see if it is a mature skeleton, immature skeleton. Once mature skeleton is presented, your DD changes when it is involving the subarticular surfaces. Why can't this be a metastasis? Because metastasis would have been presented with the more amount of destruction, more wide zone of transition, multiple lesions. Usually, those involves metaphysis that does not try to reach up to the articular surface, but that is not a hard and fast rule. But the wide zone of transition, excess destruction, associated soft tissues are the rules for the metastasis. So, DDs for the subarticular lesion in the closed epiphysis in a close mature skeleton, when there is a presence of GCT, you should always consider 4 to 5 DDs always, which could be a giant cell tumor. Metastasis always when there is a age is more than 30, 40 years. Hemophilic pseudotumors, very rarely when you have features of that. HPT Brown's tumor, because there is usually presence with the Brown's tumor. Multiplicity is the most important features of them. Okay, chondrosarcoma, osteoblastoma, all these lesions are TD, but when it depends on the location as well as the age of the patient. So this was the GCT with secondary ABC. So always remember, blood fluid levels does not means only ABC. ABC, primary ABC occurs less than 30 years. More than 30 years, secondary ABC, we have to. So if you have to differentiate between a pure ABC and a GCT, what is the one thing what that going to help you? What is GCT, the solid tumor or cystic tumor?
Solid,
And so ABC is
cystic.
very good. So GCT is a solid tumor, that is a giant cell tumor is a fibrous tissue. That's why it looks blackish or hypointense on this T2 weighted images. And after giving contrast, the soft tissue enhances, whereas ABC is cystic areas. So cystic lesions will enhance, showing the peripheral enhancement, but there will be no definite soft tissue components. Okay. So tell me the 4 to 5 lesions when there is an absent of periosteal reactions in the epiphysis or proximal metaphysis, when absence of periosteal reaction or a presence of periosteal reactions virtually rules out those lesions.
So, GCT.
Presence, I'm telling presence of periosteal reaction in absence of pathological fracture rules out those lesions. So fibrous dysplasia, NOF and enchondroma, unless there is a pathological fracture, does not present with the periosteal reaction. So always remember basic points. Okay. Okay, we'll go to next and Dr. Farin, you can unmute it, take your time. And you have been provided with the first image is T2, second is diffusion, third is SWF, fourth is post-contrast T1 FS images, pre-contrast T1 images are not given because it was not anything, nothing was bright, and one spectro image. You can go ahead and describe it.
So good afternoon, sir. I'm been provided with MRI selected axial sections. In the T2 axial image, there is a well-defined heterogeneous hyperintense lesion in the right thalamus, causing mild mass effect and surrounding edema. On
Very good.
diffusion,
One thing I want to just interrupt you. You said lesion is T2 hyperintense. Can you tell me on what basis you are told the lesion is hyperintense?
so compared to gray matter,
So you are thinking this is a gray matter. Compared to the gray matter, do you think it is hyper? I'm talking about the lesion.
so it's iso to hyper, sir.
Very good. So major component of the lesion, it's matching with the gray matter. And the central part, which is light, brightish, it is a little bit hyper intense compared to the gray matter. If you see the major portion of the lesion, it is matching with the gray matter, correct?
Yes, sir.
Okay. So continue the description.
So on diffusion weighted image, there is no significant diffusion restriction except for the peripheral right side.
Very good.
And on SWI images, there is peripheral blooming and few punctate foci of blooming in the central region. On
Excellent.
on post contrast image, there is irregular thin rim enhancement,
Very good.
and on spectroscopy, there is elevated lipid lactate levels, elevated. There is elevated lipid lactate level seen, sir.
Very good. What about the choline, creatinine, Na?
Uh,
So forget about this second spectrum. This is inversion to C just to Z. Just concentrate on this.
so which one, sir?
This one. Here it is. I'm pointing this.
Choline is not that elevated, sir.
Very good. Excellent. So what is your diagnosis based on this lesion?
So since choline is not that elevated and there is lipid lactate peak, my first differential would be tuberculoma.
Okay.
Uh, then any
If,
other CNS infections
like,
like toxoplasmosis.
why you are saying toxoplasmosis? What is the feature of toxoplasmosis? Why you are saying toxoplasmosis? Where is the location?
Usually basal ganglia with
Thalama, periventricular regions. Excellent. Okay. So your DD is tuberculosis. What is the feature? What is if you say tuberculosis, which stage of tuberculosis it is presenting as per you? Does tuberculosis present with the bloomings?
if there is associated hemorrhagic component, it can have
That was when the tuberculosis does have a hemorrhages,
caseating tuberculosis,
will have a hemorrhages or it will have a necrosis.
necrotic components.
So does necrotic areas blooms on SW images? And if you say there is a caseating, it should show restricted diffusion. That is a liquefaction, correct?
Yes, sir.
Okay. So we have a well-defined interaxial region which is situated in the right thalamus, fairly iso intense compared to the gray matter on T2 weighted images, with some interspersed hyperintense on T2 weighted images, which has fairly non-restriction peripheral area showing brightening highlighted, which could be a vasogenic edema, which was not showing darkening on ADC images. Punctate areas of hemorrhages at the periphery, with few subtle areas at the center. Post-contrast image, thin, irregular, crenated margin type of enhancement along the margins, nothing in the central area, with surrounding non-enhancing vasogenic edema extending along the right gangliocapsular region, right extreme external capsule, with mild mass effect on the right lateral ventricle with minimal midline shift. I can't see any other lesion with spectroscopy except the lipid lactate peak. Rest peaks are not significantly elevated or reduced. This is what you are describing it as. So on that basis, what you would like to know the history and what you would like to keep as a DD. Okay, come to the one point. So describe this now. This is a contemporary case for the same.
So provided with axial MRI brain images in which T2 axial images showing a well-defined hyperintense lesion in the left thalamus, which is showing a few peripheral blooming in the SWI and smooth rim enhancement in the post-contrast T1 images.
Smooth on this side, but irregular and dragged on this side. If you see, these margins are very much irregular. On this side, it is smooth. Okay,
Yes.
continue.
Yes, sir. And in spectroscopy, there is elevation of
Yeah,
choline peak.
very good. So basically, I will read choline to create ratio is about 3.6.
Yes, sir.
Okay, so now two contemporary cases. On these images, you said tuberculosis is a why not new primary tumor? Why not gliomatosis? Why not metastasis? Why not it is a lymphoma? Why not it is a toxoplasmosis? Or why not it is demyelination? Can it be a hematoma still?
So hematoma will show significant blooming in the GRE, and
Okay, very good. So hematoma, you are ruled out based on the signal. On signal T2, it is hypointense. Probably in the, if it was hematoma, it would have been in subacute stage where it would have been bright on T1. On T1 fat cell images, lesion is not bright. So subacute stage is ruled out. Even there is no restricted diffusion to blooming is not there. Only possible stage of blood would, in this probability, would have been in chronic. But
yes,
chronic blood would have not shot so much amount of surrounding edema. So you are rolled out hemorrhages, correct?
yes, sir.
Next.
And
Let us come to the lymphoma now. Can it this be a lymphoma? Because a lesion is in the thalamus. So thalamus has a propensity for the lymphomas, gangliomas, then metastasis, infections, and demyelinations. Correct?
so lymphoma is a possibility, sir. But
Okay. How? Okay. Correct. Very good.
enhancement will be usually homogeneous.
I'm saying that this patient is immunocompromised.
Okay. Then in lymphoma is a possibility, sir.
Okay. How you rule out the this is not a lymphoma? I'm telling this is not a lymphoma. And if yes, you have to tell what is the positive find for lymphoma, and if not, why not?
Lymphoma can usually shows diffusion restriction.
Excellent, because it's a cellular tumor. Tell me five cellular tumors of brain fast.
Glioblastoma, lymphoma, uh,
Most common.
metastasis,
Okay, most common. I'm still coming to the point. Cellular, I'm not asking about
meningioma,
neoplasm.
meningioma,
Cellular. Very good, excellent. Meningioma, most common cellular tumor, followed by lymphoma. In children less than 20 years, what is the most common tumor in the posterior fossa?
medulloblastoma,
Excellent. So when you are talking about the cellularity, always remember meningioma, lymphoma, medulloblastoma, and of course, mets and primary tumors can come any in time between. So tell me why it is a lymphoma and why not? You have to justify it is yes or no.
so lymphoma, since it's a highly cellular, it should show more diffusion restriction.
Patient is immunocompromised. Next, tell me.
There should be choline elevated choline peak.
Excellent. Next. So is it a toxoplasmosis? Is it a primary tumor or is it a
Mo- uh, Looks more of uh, tuberculosis, sir.
tuberculosis? You're still stuck with the tuberculosis. Okay, no problem. So let us first find out about what about this case.
More of malignancy, likely glioma.
Or can it be met?
So it can be metastasis also, sir.
So how we are going to differentiate? So basically now let us come to this case and we'll go back to this. We have something which is heterogeneously hyperintense, showing blooming again on periphery with thick irregular wall enhancement, surrounding edema, mild mass effect, showing significantly raised choline peaks when the cursor is pushed at the level of this peripheral enhancement. So possibilities of lesions like inflammation, infections are ruled out. We have come to the conclusion that this is a neoplasm. What are our neoplasms? Sitting on the thalamus at this, considering this page is being 56, glioblastoma, high grade, Secondary is metastasis or lymphoma. Tell me how you are going to differentiate based on this image. Tell me one thing which you want to do to differentiate a primary tumor from the metastasis when there is a solitary brain lesion. Pathology, pathology, pathology. Tell me.
So, blooming hemorrhagic mets are more common
That
than.
is fine. So now everything is, I am telling that this lesion can be a primary tumor, this lesion can be a solitary metastasis, or this can be a solitary lymphoma. Just tell me one thing what you would like to do, which you ruled out everything.
Sir, in this spectroscopy, the perilesional edema will show elevated choline peak in
In
metastasis.
the,
In
in the,
metastasis.
and
In
what will happen in primary tumor?
primary tumor, the perilesional edema will not show elevated choline peak.
Okay. What is the pathology of primary tumor? If I was with this, what you are telling is very correct, but I think you are confusing it. So when there is a primary tumor, like a high-grade tumor, it has a microinvasion, microinfiltrative, and microangiogenesis property. So primary tumor in the periphery, when is there, this perilesional edema, which does not enhance on contrast. When you put a spectro in a primary tumor, it will show raised choline because it has a microinfiltrative property. But a metastasis in the perilesional edema won't show the raised choline. So that is the one thing which you will able to differentiate between the primary tumor versus metastasis. Perilesional edema, put a spectro, put a perfusion, raised perfusion and raised spectroscopy always favors primary tumor. Normal perfusion, normal spectroscopy in the perilesional edema always favors metastasis. Now go to back to this case. As you said correctly, it could be a lymphoma also a possibility, but lymphoma is being a cellular tumor, usually will present with a restricted diffusion, usually is T2 iso2 hyperintense, usually doesn't present with the hemorrhages. The only condition where lymphoma presents with the hemorrhages is Epstein-Barr associated with the lymphoma or other treated lymphomas. These are the only two conditions where hemorrhages present. Otherwise, unlikely to present with the hemorrhages. Other than that, it should be showing peripheral enhancement, choline peak should be raised. Other possibility, as you were saying, tuberculosis in the stage of KC18 would have shown in a restricted diffusion. Again, tuberculosis would show irregular margins and hemorrhages are very uncommon tuberculosis. Toxoplasmosis is a diagnosis, your differential diagnosis is told T2 blackish lesions on T2. What it indicates? Or a hypointensity on brain images, what it indicates?
Amplification,
Fibrosis
fibrosis.
and inflammatory granulomatous tissues. So blackish on T2, hemorrhages within it, peripheral enhancement, normal choline with lipid lactate could be a tuberculosis or a toxoplasmosis because of the hemorrhages. The lesions in the brain which shows hemorrhages are very few, especially when there is an infection inflammation. So basically, one of the most common being the toxoplasmosis, fungal infections, and of course, high-grade tumors can present. So this was a toxoplasmosis, and this is a primary tumor because perilesional edema is showing the raised choline peak. So I want you to concentrate on the same pattern of the lesion, but a different diagnosis. If you come to this, I want to just learn four things. Lesion being heterogeneous areas of hemorrhages, peripheral thick heterogeneous enhancement locations. If choline peaks are normal, only lipid lactate comes, favors infection, inflammation, and could be a lymphoma. Lymphoma in the brain, it usually doesn't present with hemorrhages. Primary tumor at the periphery will show raised choline. Metastasis at the periphery won't show choline. Okay?
Yes, sir.
Okay. So we'll move on to one next case. We are short of time, so we'll take this one case. Dr. Deepak, you can unmute yourself and take this case. So patient has present with hoarseness of voice. Neck, I'm just giving you a clue. This is a neck images. Neck means symmetry. You have to see symmetry. Everything in the neck is symmetry. Absence or presence or something is absent is always a pathology. Just technically tell me the positive findings.
Sir, right-sided vocal cord deviated slightly towards midline.
Okay. What is this? This is epiglottic fluid. Compared to the opposite side, it is thickened. What is this? Laryngeal ventricle dilated ipsilateral. What is then happening? Epiglottic fold is thickened on that side. Laryngeal ventricle is dilated. This is something like a mushroom-shaped vocal cord. What is happening in these two images? What is their symmetry? See and tell me what is happening. Always look at the entire slide. Entire slide, see this, concentrate on this. So basically, we are finding there is a features of right vocal cord palsy. You see this image till the time I will explain that. Is vocal cord palsy on the right side with mushroom shaped. Mushroom shaped has come because the dilatation of laryngeal ventricle, thickening along the posterior aspect, thickening of epiglottic fold, ipsilateral piriform fossa dilatation. Specific signs, ipsilateral dilatation of piriform fossa, thickening of epiglottic fold, and this. So these are the three signs of specific signs of vocal cord. So this is a unilateral right vocal cord palsy. What is happening here? Symmetry. See the muscles.
Uh, more bulk is more seen on the left side, sir.
Very good. Which muscles? These muscles are looking okay. Which is this muscle?
Sternocleidomastoid.
Very good. What is happening on the right side? Even on this
Atrophy is there.
image. Absolutely, atrophy is there. Excellent. And what is happening to this? This is what?
Muscle bulk is more on left side, sir, whereas it looks atrophied on right side.
Very good. So you have a right side sternocleidomastoid atrophy. You have a right side trapezius muscle atrophy.
Trapezius muscle atrophy.
You have a right-sided vocal cord palsy. What you would like to do when patient comes with the hoarseness of voice, you are seeing in the CT images, where you will try to see the lesion now?
That means vagus nerve and spinal accessory nerve has been involved.
Barabar. Okay, perfect. So at a same, in a one patient, two nerves are involved. What is the probability of the lesion being where?
Somewhere higher up in the base of the skulls.
Very good. Tell now. This is the higher section of the same patient. This is a plain study. This is a contrast study. And this is a bone window. So something abnormality in which region? What is this region?
Jugular foramen.
Excellent. So we have abnormality in jugular foramen. What is happening here? What is this bone? This bone. What is happening here?
It has been destroyed, sir. Destroyed.
Excellent. So there is a permeative destructive area in the right adjacent petrous apex, expansion of the jugular foramen. On contrast, how it is enhancing?
Intensely enhancing, sir.
Okay. What you would like to do next? Take the MRI for the same patient and tell me.
Sir, intensely enhancing lesion noted in the right jugular foramen with prominent flow voids.
Excellent. So salt and pepper appearance on T2 weighted images, things are salt, pepper are there. And you have an intensely heterogeneous enhancement extending along the course of jugular foramina. Where it is trying to go? So it's going extracranially along the dura, adjacent to the hypoglossal canal. So your DDs is the lesion is explaining your all the features of this vocal cord palsy, spinal sternocleidomastoid atrophy. In fact, patient has a tongue atrophy as well.
Paraganglioma.
Excellent. What is the DD for this? So much intensely enhancing heterogeneous jugular foramina.
Sir, schwannoma is one of the DD. Schwannoma is one of
Excellent.
the DD.
Another DD?
Meningioma in that.
Jugular meningioma. And so much vascularity with destruction. What is your first thing if patient is more than 40 years?
Metastasis.
Excellent. So heterogeneously enhancing lesions in jugular foramina, most common being paraganglioma, other being meningioma, third being schwannoma, and four can be hypervascular metastasis. So how you differentiate jugular paraganglioma, meningioma, and schwannoma?
The paraganglioma have that because of salt and pepper
Vascularity,
appearance
they
flow
will have a
mass
salt and
mass.
pepper swell, heterogeneously intensely enhancing. What about the schwannomas?
It will have little heterogeneous appearance with the cystic areas.
Okay. Does it cause bony
and-
destructions like this?
No, sir.
It will cause mass
not.
effect, mass effect, max to max remodeling unless it's a malignant peripheral nerve sheath tumor. And what is the growth pattern? You will see if it was jugular schwannoma, how the nerves travel. It will be always along the nerves. So nerves from the jugular foramina travels always towards the medial aspect. The pattern of the growth will be always towards the medial aspect. Okay. If it was meningioma, then meningioma, 3 points related to the destruction of bone, related to the signal, and related to the pattern of the involvement. So only 3 points you have to remember in jugular fossa: signals, enhancement characteristics, how they are growing, and fourth, the bony destruction plus minus. On that 4 points, tell me. First, signal.
Sir, it will be iso-intense.
Okay.
To gray matter.
Contiguated images could be mostly iso to hyperintense, being a cellular lesion. Next, contrast could be heterogeneous intense enhancement. Third important for how
it will
lesion
sclerosis.
extends.
Surrounding sclerosis will be there, sir. Bony sclerosis,
Okay.
not destruction.
Okay. Does the bone density is maintained or reduced, or it is maintained, but there could be a permeative destruction or sclerosis only?
Sir, in the region of CP angle, there CP angle meningioma, like
I am asking about jugular foramen
yes.
only.
I think
So basically, very good. So basically, you have to differentiate of jugular lesions. Most important hint it is paragangliomas, then schwannomas, third is meningioma. Fourth is, of course, hypervascular metastasis, but we will see more expansion, more of the destruction, associated soft tissue, multiple lesions. We have known history and starts to involve, rather than to epicenter would not be a jugular foramen, either it would be something in the CP angle or something in the bone. So let us revise in the jugular foramina. Only 3 points you should always remember: signal character as well as heterogeneous intense enhancement. What is most important thing in jugular things are the how they grow. So basically, the paragangliomas usually grow along the superolateral. So always think this is a coronal plane and see how they're going to extend. So this is your jugular foramina. So lesion will always extend along the superolateral aspect. One thing. Second, bones. There will be a permeative destructive lesion with loss of normal bony architecture. That's it. These 2 points you should always remember. Rest salt and pepper, the salt and pepper, heterogeneous enhancement, no. But you always remember in jugular paraganglioma, always grow superolaterally, and there is a loss of normal bony architecture and excellent erosions of the margins. So this is called as permeative destructive. What happens in the schwannoma? They will always grow along the course of spinal accessory or vagus nerve. So it will have a smooth margins. They will have a preserved cortex and preserved bony architecture. Bony destructions are unlikely. So growth is superiomedial. And what happens in a meningioma is the growth is circular. It will grow all along because it will grow along the dura. So there will be a centrifugal growth. The typical feature of foramen, jugular foramen meningioma, they have a bony sclerosis as well as permeative type of irregularities. What it means that margins by the lesions will be irregular. There will be a loss of normal cortex, but the density will be preserved till the end point. What I mean to is, see this image now. If you see, this is margins are very much irregular, but still the bony density is preserved. So this is nothing but the permeative sclerotic type of bony involvement, which is very typical for meningioma of jugular fossa. And if you see here, this is like inner cortex is broken. There is a erosion, destruction, and bony density is not preserved. So this is basically permeative, destructive type of bony involvement, which is seen in jugular paraganglioma. So I want you to remember only these 2 points related to the jugular foramen, three important lesions. What signal? I want you to remember bone, how it grows. Paraganglioma will grow superlaterally and will have a permeative destructive sclerotic. Sclerotic means bony density is. Thank you, doctor.
Cortical thickening.
Okay, right-sided. Do you see
Both
only
sides,
right side?
both sides, sir. Both sides. The cortex is thickened, showing diffusion restriction.
Mm-hmm.
Diffuse cortical.
So you are seeing something diffuse, which is symmetrical. First important thing, is it bulky? Is it symmetrical? Is it hyperintense with restricted diffusion? 5 things you have to tell. Is it symmetrical?
Symmetrical, sir.
Excellent, sir. Is it involving cortex?
Yes, sir. More on the cortex.
Does it involve white matter?
No, sir. White matter looks fine, sir.
Excellent. So we have a cortical restricted diffusion or brightness on ADD images. Do you see everything is involved or anything is spared? And what is happening on T1 weighted images? What happens to the, tell me about cortex, basal ganglia, thalama. What happens to them? Anything is spared or not? These are the 5 points I want to know, and anything you are seeing on the T1 weighted images, and what is your diagnosis?
Occipital little spared, I feel. Sir.
Excellent. Very good. So basically you are seeing that occipital lobe is spared. What
Spared.
happens to the basal ganglia and thalamus? Do you think thalamus is having signals?
Thalama also hyperintense signal. Gray matter
Excellent.
is signal. Basically, gray matter involving deep gray matter.
Very good. So we have a entire cortical restriction, even involving, this is what is the anatomical location of this structure?
Cingulate gyrus, I feel.
Excellent. Do you see this is bright little?
Yes, sir. Bright, sir.
Yeah. Insular cortex is bright.
Insula, yes, sir. Insular cortex, both insular cortex.
So basically, whatever the image is shown, everything is bright at cortex except occipital lobes. Am I correct?
Occipital. Yes, sir. Yes, sir.
Even thalamus are involved. Am I right?
Yes, sir.
So what are your differential diagnosis based on it, and what are your thoughts?
Metabolic.
Metabolic. Okay. Which metabolite will present as a cortical swelling with restricted diffusion? What are the most common things you would like to think?
Inflammatory etiology.
Inflammatory etiology, do we involve only cortex? Does they involve subcortical region? Are they symmetrical? Inflammatory process you are thinking?
Not sure, sir.
Okay. So what other things you can say? Suppose patient had a cardiac arrest. What you will think of? Excellent.
Ischemia also gives this. I mean, we have to see the cerebellum also, sir. Like,
okay.
White
Forget about
cerebellum.
cerebellum. Only on these images, what your cerebellum is normal. On these images, can it be this hypoxic ischemic insult?
Could be, sir.
Very good. What could be? Why this is not and why this is yes? What could be the DDs to this? So basically, you are saying I have a complete cortical swelling, bright on flare images with involvement of cingulate gyrus, insular cortex, with thalamus involvement is there. preservation of occipital lobes. So what are your DDs?
In HIE, mostly posterior lobes and deep gray matter are more involved, sir. Deep gray matter.
Excellent, very good. Excellent. So basically, right now, posterior lobes look spared. Okay,
Spared,
next.
sir. That is negative for HIE.
Okay, but still can be HI. Very good. Excellent point. HI 1 point is correct. So next DD, tell me. Anything in the image that is giving clue? What is the last image is
T1.
okay. What is it is giving? Anything is adding to you?
There is chunking of ventricles.
Okay, fine. Any structure? What is the structure? Do you think it is bright on T1 weighted images or it is like normal? This is the putamen.
Yes,
This
sir.
is what structure?
Lentiform nucleus.
Okay, this structure is what?
Internal capsule, sir.
Internal capsule will be here. This and this is the internal capsule. So this is the anterior limb. This is posterior limb. What the structure is this? Above the thalamus, this is the posterior limb. So what structure will be there? Globus pallidus. So
Globus pallidus.
the GP, so globus pallidus should have the signal like putamen. Do you think it is the same signal as the putamen?
No, sir.
Is it bright or black?
Globus increased signal intensity.
Okay, what does to increase signal in bilateral globus pallidus indicates being on a T1 weighted images?
Metformin.
Correct, tell me.
Toxicity. Metformin toxicity.
Okay, only metformin toxicity. So T1 bright means what are the structures will be there?
T1 bright.
That too very symmetrical. T1 bright means there is shortening.
Yes, paramagnetic deposition.
Excellent. So paramagnetic deposition could be related to any iron,
metabolic,
hemosiderin, metabolic,
metabolic
total parenteral
etiology.
nutrition. So GP bright means now you have bilateral symmetrical GP and cortical swellings are there. What are your thoughts now?
Metabolic cause of
Like
iron manganese deposition.
iron manganese deposition is done only on this basis. What are all these features suggesting so much cortical swelling?
No.
So basically cortical swelling indicates this could be hypoglycemic insult, metabolic insult or hypoxic ischemic insult. Okay. When there is involvement of cortex and deep gray white matter, we think in terms of hypoxic insult, hypoglycemic insult, or it is a metabolic insult. Metabolic insult, especially in the presence of T1 bright signal in the both globus pallidi, which is due to paramagnetic substance, is related to the iron manganese deposition, which is very much common in the hepatic encephalopathy patients. So hyperammonemia will be there. So cortical gyral hyperintensity. And as you said, this a peculiar pattern is there, is the occipital preservation, which is unlikely in cases of HI because they have a predominant involvement of oxylobe and thalamus. Okay.
Hepatic encephalopathy.
Very good. So hepatic encephalopathy. Why hepatic encephalopathy has a preservation of occipital lobes? And any other lobe is preserved in a hepatic encephalopathy showing so much of a cortical swelling. Occipital lobe is spared. That you agree?
Cerebellum is, as you said.
Okay, that is fine. Another peculiar cerebellum will be spared till in all the process till the entire because posterior circulation will be preserved till late stages. Because hepatic encephalopathy is due to associated increased ammonia. The neurons present in the occipital lobe and perirolandic cortex are resistant for the insult till the last stages. That's why occipital lobe and perirolandic lobes are almost never involvement in the hepatic encephalopathy. Always there will be involvement of insular cortex and cingulate gyrus with presence of T1. So tell me what is this now?
Hyperammonic state because of secondary hepatic encephalopathy. Need
Very
to look
good.
for
So tell me
liver pathology.
dysfunction. Correct. So let us revise this and finish it off. So again, you have a cortical swelling. Now basal ganglia is involved, occipital lobe is involved. What are your
Hypoglycemia.
DTs? Hypoglycemia could be there. Can this be HI?
Sir, could be the HI.
Very good. What is a peculiar feature of hypoglycemia in adults? So tell me, these are two images. What is the difference between two images? Only one difference. Here thalama is involved, here thalama is not involved, correct?
Sir.
So basically, when there is an involvement of occipital lobes, your probability of hepatic hyperpuremic encephalopathy is almost ruled out. Then you come
Okay,
to
sir.
the DDs of hypoxic ischemic insult, hypoglycemic insult. In adult, thalamus are resistant for hypoplasmic insult. So when you see a presence of deep gray nuclei with involvement of thalamus and posterior
Sir.
occipital lobes, it indicates HIE. Presence of thalamic involvement almost always rules out the hypoglycemic encephalopathy in adults. Okay.
Okay, sir.
So simple points: cortical restricted diffusion, cortical swelling in adults with preservation of occipital lobes, and perirolanthic region
Perirolanthic
favors hepatic
cortex.
hepatic
Sir.
encephalopathy.
Okay, sir.
Presence of occipital lobes and deep gray nuclei plus thalamus,
Rules of
HIE. Very good. Rules out hypoglycemic, so favors either a other DDs
HIE.
or a hypoxic. Yeah.
Yes, sir.
So all this with absence of thalamus could be a hypoglycemic or either.
Hypoglycemic.
Because if we consider this as a hypoxic ischemic, it always, when there is involvement of occipital lobe, basal ganglia and thalama are always involved. Okay.
Okay, sir.
I think we are running out of short time now. Already we have crossed the 8. We'll stop because there are so many cases. We'll try to take it some other day.
Akhil, can you please have a look at the Q&As once?
1 second. Q&A. Please show second line diagnosis of lumen. The chest X-ray showed initially. Okay, second slide. Okay, I'll go back to the second slide. Everyone is wanting to see that. So basically, this is the X-ray I was talking about. That was what we see in day-to-day life when we counter the X-rays in this. So if you see this X-ray, it has a retrostep here, discontinue with the cortex, representing the fracture at the junction of medial 2/3 and anterior 1/3 of the lateral 1/3 of the clavicle. So if you see, there is a one thin around 2 mm line passing from medial aspect going to the lateral, and I'm seeing the paucity of the bronchiovascular markings. So basically, when there is a presence of true pneumothorax, vascular markings will be 100% absent. The pleural line will be very thin. It will be very sharp, as you can see, and it does not fade away medially or laterally, and it does not extend beyond the chest wall, which favors a pneumothorax. Whereas if you see this case now, this case, look at this chest wall. Look at this density. This density, look at how it was fine, thinner, sharper. Look at this. It's like a so tummy talk, thick, almost like a centimeter size, extending from above and going beyond the extents of chest wall, which will be never seen in cases of pneumothorax because pleura doesn't extend beyond the neural floor. Its medial margins is very blurred. Lateral margins are very much sharp. And the most important feature, so look at this bronchovascular markings. They are so neatly seen. If in the presence of true pneumothorax, we should expect that there should be absence of the bronchovascular markings, which is the most specific signs. So when you interpret a pneumothorax in a day-to-day ICU X-rays and daily practice, always see those that this is not crossing the chest wall. It has a prominent bronchovascular markings beyond what we are seeing along the chest X-ray. So this is nothing but the same deception. So I'm given on this image, pneumothorax, very sharp margin, extends along the confluence of the chest wall, does not go beyond. Otherwise, where the skin folds, it extends across and crosses beyond the chest wall, and it will be seen beyond the chest wall. Its margins are so thick. On the lateral aspect, it is sharp, medial aspect is, but that is what is that is day-to-day practice. We should know, learn. This is so basic. We should always realize this. Another click, please quick review of all diagnosis of all places. What was the answer of one with the left slip liquid? The 1 second. So basically, this case where only lipid lactate was raised, where rest of the metabolites were normal and lesion was T2 hypointense showing peripheral hemorrhages, no restricted diffusion, peripheral thin enhancement. We have ruled out the neoplasm metastasis based on the basis of spectro and additional findings. So it was a toxoplasmosis. Lymphoma is also ruled out because hemorrhages are also present, very blackish lesion without restricted diffusion and normal choline peaks. And the other one was this was a primary tumor because it has a raised choline creatinine ratio. But this could be still a solitary metastasis. How you differentiate between the primary tumor versus metastasis based on the single imaging parameter is do a spectroscopy around the perilesional edema of the lesion. Put a spectroscopy here where there is a no enhancement, where you feel this is a vasogenic edema. In that perilesional edema, if the spectroscopy shows raised choline levels, it favors the primary tumor because it has a microinfiltrative microangiogenesis property, while metastasis doesn't have. So that is a one specific sign where you will differentiate a primary tumor versus a metastatic lesions. Anything else? Okay, answer live. I think all the questions are answered. Oh, sorry, I can't explain all the uh, uh, slides because there are another 10 cases which we'll try to cover in any other time. Thank you.
Thank you,
Yeah,
sir.